other sides right now too? Okay. Well, so good morning. So I'm Tamara Fusco. I'm a practicing general pediatrician, and I practice with Mercy down in Nixa. Now, anytime you sign on with a place, I've been with Mercy for over 15 years. Before that, I practiced in Alaska, general pediatrics. Whenever you sign on with any place, what do they want you to do? They want you to join the committee, right? So, about 10 years ago, I was asked to join the lactation committee. And I have to tell you, I think the only reason they asked me is because I was a pediatrician and I breastfed my own babies. I really felt like my medical knowledge was about this big because I was a pediatrician and been practicing for multiple years. So over the last several years, I've really tried to increase that knowledge. In 2012, I became an international board-certified lactation consultant. And in 2013, I was honored to be designated as a fellow of the American Academy of Breastfeeding Medicine. Actually, it's just the Academy of Breastfeeding Medicine. And so I'm hoping to share some of that knowledge with you guys today because it may be different in your experience, but certainly in my experience with medical school and residency, I really have very little knowledge on breastfeeding or the science of breastfeeding. So, trivia points. Anybody know this portrait right here, this painting? Any guesses on the painter? Everybody's on the weekend already. This is actually Picasso. This is before he came to the stage. So today, my objectives of the talk is that I want to talk about the normal physiology of human lactation. I do want to discuss the components of actual human breast milk. I want us to be able to describe the normal newborn breastfeeding course in regards to feeding behavior, weight loss, weight gain, and progression. I do want you to know the major organizations who actually advocate for breastfeeding, and I do want you to have some resources when you leave here today for breastfeeding. Okay. So as Aristotle would say, there is a reason behind everything in nature. We're mammals. We're warm-blooded. We produce milk for our young, just like other mammals do. So let's start at the beginning. Everything always seems to start with anatomy and physiology, right? So let's get started at the beginning. This is a pretty typical depiction of the human breast in our anatomical text with it. Now, simplistically, when I think about the breast, I really think of two major components. I think of stroma, our supporting components, and I think of the parenchyma, really the functional components. So when we look at this, we do see that as far as our supporting components, we have our chest wall, our bony structure here. We have the pectoralis muscle lying just in front of it. We do have, and it's not depicted here, suspensory ligaments, Cooper's ligaments, that actually suspend the breast from the chest wall. We have a large amount of adipose tissue surrounding the parenchyma, as well as actually intercalculated within the parenchyma. We have blood vessels, we have nerve innervation. And on top, of course, we have a normal skin layer with a deeply pigmented area and a protrusion, which is the nipple. So the areola and the nipple. Pretty basic, right? Now, our parenchyma consists of multiple individual alveoli, which are clustered into lobules. Okay, so individual clustered into lobules. We have ducts that connect, and then openings that go out of the nipple. I do want to point out one thing right here. If you see lactiferous sinus, we're going to talk about that in just a minute. So in general, this is a pretty common anatomical sketch that we would see. So the anatomy of the breast was first described in 1840 by Sir Astley Cooper. And you know what, really for the next 160 years, nothing changed. A lot of things don't change in gross anatomy. What he did to find out the structure of the breast is he actually took hot wax, he injected it in all of the nipple pores, and the wax solidified, he dissected, said, oh look, we've got lobules, we have multiple of them, we have holes that come out of the nipple, here's the breast. What he noticed, though, is right beneath the areola, he found some areas that seemed to be dilated, and he called those lactiferous sinuses. And so he proposed that that was a holding area for human milk, that once it was made, it was just kind of stored at the edge of the alveoli. Well, in 2005, we actually have a revision of some of what we thought about the breast anatomy. That just doesn't usually happen in breast anatomy. So Peter Hartman and his group out of Perth, Australia, did ultrasound imaging of the breast, and they actually noticed a few different things. And so I want to tell you guys, because you may actually see some outdated text even now on the breast anatomy. The first thing is the lactiferous sinus is not a true anatomical component. It's more of a potential. All right, what does that mean? It means when he injected the wax, it caused that dilation because it was a potential dilation. Milk is not stored there. Milk is stored in the alveoli. When it's coming down the duct, you may see that dilation is where the baby takes in the milk, but it is not a true component. Actually, the ducts are much more branched than what Sir Ashley Cooper even announced with it. What he also noted is that the first, if you from the nipple, really the first 30 millimeters are very important, and that's really where you see the concentration of the functional component, the parenchyma. Why is that important? If we're having a resection of breast tissue, it's very important that we know, where are we going to get into trouble and where are we not. Why was the lactiferous sinus even important? It changes on what we think, where we think the baby should latch. So if you are helping a mom, or you're having a baby that's starting to thrive, you can evaluate, make sure that we're not just thinking that milk is right there at the tip. It's not. It helps our latch and helps with things like that. So anyway, I thought that was really interesting. So let's get a little bit closer and actually look at the functional part of the breast. So once again, we have our alveoli clustered in the lobules. And this is just a closer look at what the alveolus looks like. So it's similar to what we see in the lung, but obviously very, very different function. So we have a hollow, rounded shape that is lined by lactocytes. And it's in these cells that the milk is actually produced. On the outside of the alveolus, like what you would see in the lung, we have a rich blood vessel complex. And you can see it a little bit more down in this picture. Interestingly, we also have myoepithelial cells. So there's muscle tissue around the alveolus that actually goes up into the duct. So blood comes to the alveolus. We have passive diffusion of nutrients, of other components into breast milk. We also have active transport. And then when the milk ejection reflex happens, myoepithelial cells contract. Milk is propelled into the ductule, which you'll see also has muscle, and then eventually makes its way out to the nipple. It's pretty straightforward. So let's go ahead and start talking then about the physiology. Let's talk about lactogenesis, which is the production of breast milk. And now, so we divide that up into 3 stages, lactogenesis 1, 2, and 3. When a young lady is pubertal, but in a non-pregnant state, she has started having some rudimentary growth. She started having differentiation of alveoli, globules, ducts as well. When a woman becomes pregnant, we see a whole different compilation of hormones. We see increases in estrogen, prolactin, progesterone, and we start to see change in the breast tissue. So if a woman chooses not to become pregnant, we won't ever see what we consider a more mature differentiation of breast tissue. So those hormones will act to further differentiate the breast, increasing our alveoli, increasing our lobules, and this starts the stage of what we call lactogenesis 1. So if you choose not to get pregnant, obviously you're not going to have any lactogenesis. It causes the differentiation of the mammary gland, and at 16 weeks gestation, which is roughly 3 to 4 months gestation, the woman actually has the capability to start producing colostrum, which is that initial milk. So very early in pregnancy. Lactogenesis 2 does not occur until the woman has delivered. Okay? When we have delivery, we have the removal of the placenta. We have a change in our hormones. It's a progesterone drop, prolactin is exposed, and that will trigger the onset of what we consider true milk production. Initially, as we're lactating, the first couple of days, it's the colostrum she was able to produce much earlier. But about day 2 to 4, with that action of the prolactin, you see the milk starting to come in. I put it in quotes because some people don't really like that term. This is an endocrine process. Okay, so if you choose not to breastfeed, or one chooses not to breastfeed, this is going to happen regardless. This is an endocrine process. Now, lactogenesis 3 is what we consider to be mature milk production. This is maintenance production, and it doesn't usually begin until around day 9 to 10. This is not as driven by the endocrine system. The If a woman chooses not to breastfeed, she will dry up and not to go through lactogenesis 3. This happens about day 9 or 10. It is going to be more of a supply and demand phenomenon. So we'll talk a little bit more about that too. So here's a schematic, just kind of, once again, detailing the hormones that we see in pregnancy and in lactation. So in pregnancy, we start seeing a rise of estrogen. We certainly see a rise of progesterone that's maintaining that uterine lining and maintaining the pregnancy. We also see a rise in prolactin. All three of these are important for that differentiation of the mammary gland and that initial part of lactogenesis 1. Now, prolactin, besides helping differentiate the mammary gland, is very important for actual milk production as a stimulus. However, progesterone has an inhibitory effect. So, and oxytocin doesn't play much of a role until we get to the labor process, start getting a uterine contraction. Okay? So then we see birth happen. Once again, that placenta is removed, progesterone levels plummet, and our prolactin then is able to use, it's not inhibited from the milk secretory component of it. With each nursing, we see a spike in prolactin. So nursing will increase that hormone to increase milk production. However, if we follow this out, the rise of the spike becomes lower and lower until about 2 weeks when we really are not seeing much of an increased level at all. And that's how we know too. Remember, this is the endocrine driven. By that 9 to 10 days to 2 weeks, it becomes supply and demand. So we're still trying to figure out all the roles that prolactin have because we don't really understand all of it, but it kind of gives you an idea of why we say endocrine versus supply and demand. Oxytocin is more important for the milk ejection reflex. It causes uterine contraction, so it works on muscle, works on the muscle and the alveolus of the mammary gland. And we also see spikes with every nursing, okay, and we continue to see that as well. Now, as an aside, oxytocin, extremely interesting. Lots of research going on, actually with maternal postpartum depression as well. It's also called the hormone of love. We know that it helps with bonding with moms and babies. And so besides just being a muscle, it really is an interesting hormone, and you'll probably hear more about it over the next couple of years. So speaking of oxytocin and the milk ejection reflex, okay, so milk is stored in the breast. It doesn't usually just, you know, you may have some dribbling, but it doesn't usually just squirt out on its own. We have to have oxytocin, and we have to have something called a let-down reflex, get the milk from the alveolus out of the breast. So this is after we've had our endocrine driven and we're into our supply and demand. What we know is that when the baby sucks on the nipple, we have a neuronal message that goes up into the hypothalamus. And so the hypothalamus then sends the signal to the pituitary gland. From the posterior pituitary is where oxytocin is made and sent out, causing the muscle contraction and the release of milk during the feed. The anterior pituitary is where prolactin is made, and that causes our milk secretion. So milk production, supply and demand, you have to have both nipple stimulation. So this is also important if we have a mom who's had a breast reduction or a biopsy, because if they transect that fourth intercostal nerve, we may not have enough nerve stimulation to help with lactogenesis, and women can have difficulty with making milk. So anyway, nipple stimulation, and we also have to remove the milk. So those are the two things that are most important on driving a woman's milk production. Not the amount of water that she drinks, not de-stressing, but actually those two things. If we don't get nipple stimulation, we have less prolactin released, decreased milk production. If we don't remove the milk from the alveolus expands and it separates those attachment sites for oxytocin. So we don't get that. We get compression of the blood vessels, decreased oxytocin exposure, and then we also get production of this type of protein. It's the feedback inhibitor of lactation, which we're still figuring it out too, but it also will give a negative feedback for milk production.
Yeah, quick question. So in one of the graphs it showed prolactin has spikes after feeding, but drops off over time. It's kind of gone by the end of 2 weeks.
Well, it's at very low levels, and if you look further out, eventually, if a woman is nursing for a year at a 2 years, she will be back to pre-pregnancy levels and still have adequate milk supply.
So when we do the nipple stimulation, it causes the thalamus to drop,
right.
possibly oxytocin.
You're still going to get,
a little bit? Just
it
enough
is.
To
You're
cause
still
the
going to
milk
get some spikes of prolactin, but interestingly, it's not going to be up here. It's going to be down here. But you'll still get the spikes. So we're still kind of.
But baseline level is much lower.
Exactly. So we know these high levels are very important for the initiation, where we go from lactogenesis 1 to lactogenesis 2. Apparently, it's not as important in our lactogenesis 3. Okay, so human milk, what's in it? What's the big deal? So how does human milk compare to other mammalian milks? Well, let's just kind of look at the cow's milk, because that's what we typically use when we're looking at formula, unless we're doing a soy or a rice, but we look at cow's milk. So what we see is that our fat components are roughly the same, but there's a huge difference in our protein components, and there's a huge difference in our fat components, as well as the types of fat that we see. Water is the same. So some similarities, but definitely some differences in composition. Human milk, when we look at it, what is in it? Well, it's the appropriate combination of the carbohydrates, the fats, the proteins, the water. But we also see digestive enzymes such as lipase for that immature pancreatic function. We have direct immune factors. We have IgA, we have IgG, we have IgM. We have the anti-inflammatory factors, we have antioxidants. Lots of hormones are actually in the breast milk as well. Growth factors for continued differentiation of the infant tissues, carrier proteins, and then of course a ton of cells. You know, when we spin it down, it's just packed. So when we spin down formula, there's nothing there with it. We have macrophages, neutrophils, lymphocytes, all of those infection-fighting cells that we see. We have epithelial cells, especially epithelial growth factor type of things, stem cells, and we have a lot of what we consider the good bacteria. We have bifidobacteria, we have lactobacillus. When we do studies comparing babies who were breastfed with babies who were formula fed, we see very different types of bacteria in the gut. We see primarily bifidobacteria in breastfed babies, whereas some studies show that we see even enterococcus or other types of what we would consider detrimental bacteria in formula fed. So very important. Prostaglandins, vitamins, cytokines, and in fact, we still are continuing to identify a lot of the components. So basically, the breast supplies what the infant human needs with it. The baby needs energy requirements. The breast supplies lactose. The baby's pancreas is not really great, it's not super well functioning yet, so we see digestive enzymes such as lipase. We know the baby's immune system doesn't really get fully functional until about 6 months, so it's very reliant on what we get from the placenta, but also what we get from breast milk. The secretory IgA is one of the very important components, especially in the first few days of life. IgA coats that infant gut, which is immunonaive, right? It's not colonized yet. It provides a protective layer. Also, the infant gut has what we call loose junctions. We don't have the tight junctions between the cells that are loose. So we have some what we consider leaky gut. It forms that barrier, protects that as well. So very important here. We are not fully mature in a lot of the tissues. This helps with mucosal differentiation, the epidermal growth factor. Also, we have prebiotics like the very short saccharides, which will help provide an appropriate environment for the good bacteria to colonize our gut so that we adequately do absorption. And of course, we do have lactobacillus. We have bifidobacteria to support normal anti-inflammatory bacteria in the infant gut. So once again, comparing to cow's milk, because that's the one we as humans typically use if we're not using human milk, there are some big differences. So our milk protein, the casein and whey, we have a 40 to 60% ratio for breast milk, whereas in the cow's milk we see 80 to 20. The primary immunoglobulin is IgA in human milk. In cow's milk, it's IgG. So once again, very different functions of immunoglobulin. Lactoferrin provides iron to the infant, but it's also an infection component, as well as lysozyme. And we have very different amounts between bovine milk and human milk. Our short-chain fatty acids higher in cow's milk, and a lower amount of long chain and polyunsaturated fats. So although we see differences in the amount of fats, we see differences in the types of fats as well. Our other non-nutritional components also have very big differences, and so it affects bioavailability, digestibility, absorption of all of those types of things. Now, besides the differences in mammalian milk, there's differences in human milk. So we actually have what we consider about 3 types of human milk. When a baby is born and the woman has been delivered, what she's going to be producing is colostrum. And colostrum, like I said, begins about 16 weeks, that 3 to 4 month gestation period. And it's present initially up until about 2 to 4 days. It's very thick, it's yellow, looks a lot like that, or even more yellow with it. Oomycete secretes very tiny volumes. So on day of life 1, I'm looking for her to secrete a teaspoon, 2 teaspoons. Wow, 3 teaspoons is great, but I'm usually looking for 1 to 2 teaspoons. This is very high in that IgA, lactoferrin, vitamin A, and sodium. It's not real high in energy. So this is a very pugnacious, salty fluid. Okay? We don't get the high in energy until we actually start getting down to transitional and mature milk. So first 2 to 4 days, we've got very small amounts of very important infection-fighting milk. Transitional milk goes usually between days 3 to 9 or 10, and then we get our mature milk. Differences in concentrations, differences in colors.
Is that when you see if it's lose weight before the game?
We're going to get to that, but that's a great thought. Yes, because we're going to talk about that. All right, so besides the types of milk, colostrum, transitional, mature milk, we see variation in milk at the stage of lactation, but at the time of day. So you have a woman who's doing mature milk, you sample in the morning, it may be different calories, different amount of fat, different amount of protein than what it is at night. So we see variation there too. If you sample it during feeding, sample it at the first of the feed versus the end of the feed, we will also see differences. We divide it into what we call foremilk, mid-milk, hind milk. Foremilk we think of kind of like skim milk, very watery, not as many calories. Hind milk, creamy, rich, fat milk with it. So even during the same feed, from mom to mom, we can see some differences. And certainly our premature deliveries, we see a difference in that milk as well. Very proteinaceous, different amounts of chemicals. Maternal nutrition is in parentheses because in general, the making of breast milk will rob from the mom. So usually the mom's milk is very replete unless she truly is malnourished. So most of the time this doesn't matter. It does matter in cases of vitamin D. That's kind of one of our hot medical topics, right? Vitamin D deficient, oh my gosh, is it linked to this? We're really looking to that. Vitamin D, if a mom is deficient, her milk may be deficient in vitamin D as well. So that is one thing. And we supplement babies and we can supplement moms with it.
Is the problem with preterm deliveries and the actual like transition from lipogenesis 1 to 2?
A preterm delivery is usually a stressful event, right? And something that's happened in the mom, whether it's infection, whether it's hypertension, and it's usually those morbidities that will affect breast milk production. So we know things like gestational diabetes, sepsis, C-section. A lot of our preemies are born by C-section. Those can all delay lactogenesis. And so it's one of the things when I'm rallying on moms that we talk about and try to get pumping and if we need to supplement babies, if there's a medical need, luckily at Mercy we have donor milk, so I'm not having to do that. But
all other things considered, if at birth, regardless of when it happens, whether it's 35 weeks or it's 40 weeks, you're still going to get that.
You're going to remove the placenta.
The prolactin, the oxytocin, all that's going to go ahead and start the transition into lactogenesis.
Yes, and when we have a mom who delivers prematurely and the baby's in the NICU and can't go to breast, we actually try to start therapy within 6 hours so that we take advantage of that and we really start getting that copious milk production to supplement the infant. So, but all of those things can cause some difficulty in lactogenesis. Okay. So next, so let's talk about the impact that breast milk and breastfeeding, because those can be very different. Some women choose to pump and give by bottle, but the impact of breast milk and breastfeeding on health, and this is actually one of my favorites. I think babies know what they want, right? Okay. So we have been breastfeeding since the dawn of mankind, or else our species wouldn't have survived. Let me tell you, the science of breastfeeding is still relatively new. Over the last 10 to 20 years, we've had a huge amount of research so that we could truly say what we kind of thought, oh yeah, breast milk is best, right? Seems to make sense. But really, so in 2012, the American Academy of Pediatrics released this statement on breastfeeding and the use of human milk, and it supplanted a previous one that was done in 2007. And so for the very first time, we had this really beautiful compilation of the research on showing how it affected pediatric health. We'd all talked about, yes, it decreases otitis media. Yes, it decreases respiratory infections. Yes, it decreases gastrointestinal infections. But some of the really compelling data had to do with things like necrotizing enterocolitis. So for our premature babies, our most vulnerable population, necrotizing enterocolitis is either a death sentence or a morbidity sentence. You may end up with short death. At the very least, it's truly a very concerning phenomenon. So the studies that were done showed that if babies were given only human milk compared to bovine milk and fortified with the bovine milk fortifier, that we can actually decrease the rate of NAC by 77%. All right, that is massive, huge. And so actually both hospitals in Springfield here, the NICUs began giving human milk as their standard of care for our NICU babies about 3 to 4 years ago. And anecdotally, I haven't seen any of the studies, but when I was talking to someone just last fall, they said, you know what, we haven't had a single case of NAC. And we did some other things too, but we haven't had a single case of NAC. And in my mind, that is huge, huge. But we also see long-term effects on pediatric health as well. We see decreases in inflammatory bowel disease. We see decreases by 52% in celiac disease. Diabetes, both types 1 and 2 are decreased. Obesity, childhood and adulthood are decreased. And then even our most common cancers, our pediatric leukemias, are actually affected by breast milk as well. So this led to the conclusion from the AAP, which we had some of the similar verbiage that we had before, that, you know, we think breast milk is best, it's important for health, but this says, you know, we've had so much more research that this is conclusive. And then this verbiage really changed. Recently published evidence-based studies have confirmed and quantitated not the benefits of breastfeeding, but the risks of not breastfeeding. And that's a very powerful statement from the Academy, right? Because it almost gives you a negative spin. Then they said, infant feeding should not be considered a lifestyle choice. Hey, whichever one you want, it's fine, but rather a basic health issue. And so if you talk about smoking to your patients, if you talk about the importance of vaccines, you should also talk about the importance of infant feeding because it has a huge impact on health. Now, what about moms? Now, we've known the short-term benefits. We know that if we put a baby to breast, we're going to have spikes of oxytocin, that uterus is going to involute, we're going to decrease postpartum blood loss. We've also known that there's a natural child spacing that occurs. There's something called lactational amenorrhea, where a woman will not resume her periods as quickly, and so not to have such a quick pregnancy right on top of one as the woman is recovering. But some of the newer research is really talking about these long-term benefits. And so we know that women who choose not to breastfeed have increased rates of postpartum depression. Once again, lots of research on oxytocin going on. We know that women who choose not to breastfeed also have an increased rate of child abuse. People are thinking bonding issues, maybe, not sure yet. They have a decreased risk of type 2 diabetes, decreased rheumatoid arthritis, and a decreased risk of cardiovascular disease, hypertension, hyperlipidemia, actual MI as well. And then lastly, a decreased risk of breast and ovarian cancer. So this is important for the moms too. So if you have a mom who chooses to get pregnant, and then as part of that pregnancy, what happens? The body is accumulating nutrients for the baby. One of the things that they do is accumulate fats and lipids. So if she chooses not to breastfeed, that's where we don't see that exit from her body, and she retains it. And more subsequent pregnancies increase her risk, and that's what we're starting to see. So it truly may be that colostrum is better from breast milk. All right, now let's talk about the normal course of the breastfed infant. So we've just been born, and infants are very well hydrated via the placenta at birth, especially if we have a C-section, because moms are getting a lot of IV fluids. And so we know that urine output exceeds intake in days 1 to 3. Exactly. So what are we putting in? Very small amounts. What are we doing? We're peeing out that hydration, that volume. And so we expect weight loss. Small colostrum feeds, but it's appropriate for the baby's stomach. Remember, the baby's stomach and the gut are being used in utero. It is enough to prevent hypoglycemia, even though it's really more of a pugnacious fluid versus that term milk. This allows the baby to learn to suck, swallow, and breathe and handle that small volume. And we know the babies actually suck a lot more than they need. So a lot of moms interpret that wrong. Oh my gosh, my baby's sucking all the time. I know I don't have enough. But that's, what is it doing? We're increasing prolactin, we're increasing oxytocin, and it's just part of the physiological process. So this was a study from 2003, and it was looking at weight loss and timing to where you stopped losing weight and when did you regain birth weight. And so certainly we do see differences in breastfed infants versus formula, and this probably should say bottle fed, okay, because it's a different mechanism to get milk from a breast than the passive nipple that's a lot easier. So what we see is the maximal weight loss percentage in this study was about 6.6 for breastfed infants, 3.5 for bottle-fed infants, and about 6 for a mixture between breast and bottle with it. Other studies have had slightly different numbers, and overall as a pediatrician, I'm expecting a 7% weight loss is usually what I'm picking up as a normal. Okay, we typically will lose weight the first 3 days, and then we stop losing, we stabilize. We expect to be back to birth weight. In a breastfed infant, the study had 8.3. I tell you, I'm looking at for days of life 10 to 14. If I'm not seeing baby back to weight, I'm very concerned. Formula-fed, bottle-fed babies get back a little sooner. So, knowing this physiology, we should be able to give anticipatory guidance to our parents so that they know it too. We want to talk about the differences and why they're important between colostrum, between transitional and mature milk. What is the purpose? What are the amounts? Because every single week when I'm around, you always get, oh my gosh, I don't think I have enough. And so it's up to us to kind of give those expectations. We want to talk about stool progression because this lets us know the success of milk transfer. We're all going to start off with meconium, then we should transition to greenish brown, and then to yellow seedy stools. We also want to talk about growth and appetite spurts because that changes a baby's feeding pattern. Also, this is really important. This has changed since I was in residency. I used to tell moms, okay, you need to feed every 2 to 3 hours, 10 to 15 on this one, 10 to 15 on that one. And we don't talk about that anymore. That's not physiologic. Physiologic is 8 to 12 feedings in a 24 hours. You may have a baby who wants to feed every hour on the hour, but then you may go 3 hours in between for a couple of times. So we want to let them know it's not as strict every 2 to 3 hours. It's 8 to 12 for 24-hour feedings. Timing varies. Usually 10 to 30 minutes, but it varies. So I usually don't talk about time unless it's very brief. If we've only had a baby on for 5 minutes and it's a newborn, then that's usually not adequate. But in general, I don't say, oh my gosh, your baby's been on there for 20 minutes. Let's take him off. Now, it's hard, right? Because breasts aren't calibrated. How much milk is in there? You don't really know. And so these are ways that we know that the baby is transferring enough milk and it's getting appropriate nutrition. And that's our maximal weight loss of less than 8%. So remember, 7% is kind of where I consider my normal. 10% I'm very concerned and consider that excessive weight loss. The baby begins to gain weight by day of life 4 to 5. So we stabilize. Now we're on the uphill swing. And we regain birth weight by day of life 10 to 14. The stool by day of life 5 should be yellow and seedy. So it looks like mustard with little cottage cheese things in it. Normal. A lot of times we'll see a little squirt with every feed, but usually 4 to 12 stools a day is very normal. And it's not diarrhea because I have people coming in going, oh my gosh, I think we have diarrhea here. It's a problem. The urine should be dilute, colorless, 6 to 8 voids for 24 hours. Lets me know a baby is well hydrated and getting appropriate amounts. Like I said, feeding, they may average every 2, but really we should talk about 8 to 12 feeds in a 24-hour period. The baby looks good. They're got that nice tone. They're vigorous. And if we had jaundice, it should be not increasing or decreasing. So those things in combination let us know, since I can't measure how much the baby is getting, lets me know that the baby is doing fine. Okay, so in light of this research, in light of our increased knowledge of the physiology of lactation, we have seen most of our medical organizations who take care of moms and babies giving out new statements and new calls to action. This is from the Surgeon General in 2011. It's actually like a 20-page booklet, and it's for outpatient, inpatient, for community services. And basically, it is calling that if we want to change the health in the United States, we need to make some differences and support moms and babies here. Akon, this is their statement from 2007, just saying that, that we support breastfeeding for our moms and our babies. And they actually just released last month a new, it's not a statement, but it's a call to action for obstetricians to start doing more prenatal education to support breastfeeding. We talked about the 2012 statement from the American Academy of Pediatrics. And then this is from the American Academy of Family Physicians. It's a very strong statement as well. This is just from last year. It's actually saying, same thing as American Academy of Pediatrics, breastfeed exclusively, no supplement or anything else for 6 months, and then continue for at least 12 months and as long as mom and baby desire. They are calling for birthing hospitals and centers to actually do some baby-friendly certifications, starting to introduce these successful steps to breastfeeding. So they're really calling on maternity practices to change and be more supportive. And they again say, breastfeeding is a public health issue. This isn't just a choice. And if you want to do the best thing for your baby, you should at least have knowledge. Everything is a choice. So, whether you choose to smoke around your baby, whether you choose to feed your kid McDonald's every day of the week, whether you choose to not vaccinate, but as a parent, you need to have that information so that you truly can make an informed choice. And part of that would include your type of infant nutrition. All right, so definitely all of our medical organizations are saying the same thing. Now our governmental bodies on the nationwide and the state levels are getting involved in the action as well. And so this is from the Joint Commission on Hospital Accreditation, right? So our hospitals have to be accredited. It's very important for payment. It's very important to be able to do the services we provide. So it's kind of a big deal. They come around, they survey us, they look at things, and they look and see where we're where's the deficit and where our strengths are. And so in 2014, for the very first time, he said, guess what? We looked at your rates of pneumonia, we looked at your rates of post-surgical infection. Now we're adding this perinatal core measure that we're going to look at, and your accreditation is going to depend on this as well. And so they looked at our rates of elective deliveries, C-section rates, the use of antenatal steroids for our premature babies, and our rates of sepsis in newborns. But for the very first time, they're looking at our exclusive breastfeeding rates as well. And so, and exclusivity is defined as a newborn receiving only breast milk and no other liquids or solids except for drops or syrups consisting of vitamins, minerals, and medicine. So that was the first time that this is. And so now I think hospitals are starting to kind of sit up and take notice, because it's one thing to say, yeah, we all think that this is the right thing to do medically, but now all of a sudden this is affecting accreditation. Then, a little bit more teeth here. CMS is the Centers for Medicare and Medicaid Services. Many of our patients fall into this category, and their care source is through CMS. CMS has quality indicators, and that actually helps decide how much a hospital gets reimbursed. So what they said, they put this out in April of 2014, and they said, okay, guess what? Starting in 2007, we're going to change some of our quality indicators, and this is going to affect payment. And for the very first time, we're also going to be seeing exclusive breastfeeding rates. So we got accreditation, we got the money, and money talks. So we are seeing people take notice. Department of Health and Human Services has published goals for the United States, Healthy People 2020. They look at a lot of different things. And one of the things that they say to increase the health in our nation is to increase breastfeeding rates. They would like to see our rates for ever breastfeeding, whether you continued it or not, whether you supplemented. They'd like to see that across the nation at about 82%. Our data from 2014 shows the nation has about 79%, and Missouri, we're about 68%. Okay. They'd like to see breastfeeding continuing at 6 months of age, 60%, we're 42% in Missouri. Exclusive breastfeeding, no supplements. At 3 months, I'd like to see 46%, and we're down to 32%. And exclusively through 6 months, I'd like to see at least 25%. We're about half of that at 14%. So we have a lot of room for opportunity. The CDC, every 2 years, sends out something called the MP, maternity practices in infant nutrition and care. It's a survey that goes to every single hospital with maternity privileges and birthing centers in the United States. And they look at labor and delivery care. They look at postpartum feeding of breastfed infants. So are we supplementing? Postpartum breastfeeding assistance, postpartum contact between mom and baby. And this is a newer trend that you may have seen. Are we still seeing babies in nurseries and separating moms and babies, or are hospitals starting to do rooming in? Are we facility discharge care, staff training, and structural organizations and aspects of care? So they look at all of those things, and then they compile the data. The data is compiled nationally. It's also compiled individually. So each hospital gets their own scores as well. So this is the data, the latest data that we have. We should be getting more data in soon, but this is the latest that I have. So the average score in the United States out of 100 was 75. And the average score for Missouri hospitals, compiling all of them together, was 71. And so it doesn't look too bad, right? If you look at that, 75, 71, that's not so bad. But when you actually look at all the different states, Missouri, we were down at 34, so or 35. So 34 states were better than us. So it looks like there's not much of a difference, but honestly, we're definitely down in that bottom half, close to bottom fourth of the scores. Baby-friendly hospitals, those hospitals certified for breastfeeding excellence. In the United States, there were about 8%, so we lag behind internationally. In Missouri, we have less than 1% of our hospitals that were designated. Now, I will tell you that has changed, and our latest data will be better because we used to have one baby-friendly hospital in the state, in Hannibal, Missouri. Now we've actually added more. We have Truman in Kansas City, the Women and Children's in Columbia and Fitzgibbons are all baby-friendly. We expect Barnes to probably be going through the process soon. Poplar Bluff is, and Lakewood are all on the track for baby-friendly. So we're actually seeing some changes there. Babies that were being supplemented, and about 19% across the United States, we were higher at about 23%. So almost a fourth of our babies who moms say, I want to breastfeed, get supplemented before they leave the hospital. And then how about our lactation, our certified lactation assistants? We have, this is certified lactation counselor, and this is internationally board certified lactation counselor here. And so when we look, we have fewer CLCs, but we actually have a little bit more than the average on IV CLCs. But if we add them together, we're still behind. So we don't even have enough adequate staff who are well versed in breastfeeding medicine to help. Okay, so I don't expect you to know everything. Remember, I was a pediatrician, I breastfed, right? And so I still felt like my knowledge was this. But what I would like for you to know is where do you go if you don't know, okay? And there are resources in a lot of different places. Internationally, the Academy of Breastfeeding Medicine, I'm going to talk to you a little bit more about that because that's a very, it's a physician and pediatric dentist organization, and their whole purpose is to advance scientific protocols for breastfeeding. The World Health Organization and UNICEF. Nationally, we have AAP, we have ACOG, AHEC, Department of Health and Human Services. WIC programs are no longer just formula brokers. Really, they've made a huge change in their breastfeeding systems. Jordan Valley here in Springfield, fantastic. Lots of IBCLCs they employ, peer counselors. And the CDC is doing it as well. Our state level, Missouri Department of Health and Human Resources, if you go online, we actually have a state breastfeeding coordinator. We have free materials for prenatal education, for after the baby is born. So there are even DVDs, lots and lots of information from our state trying to change our numbers. Our WICs are on board, and certainly we have a Missouri chapter of the AAP, ACOG, AAFP. I'm actually the chapter breastfeeding coordinator for the state of Missouri for the AAP. Now, in this area specifically, but we have other ones around the state, we have our local and regional breastfeeding coalitions. And so usually you can kind of Google it, and they're going to have all sorts of people as resources and information as well. And then certainly we do have hospital lactation programs with consultants there. Now, just one more blurb on the Academy of Breastfeeding Medicine. This is an international organization, okay? It's made up of OBGYNs, pediatricians, family physicians, there's some internal medicine physicians, and neonatologists. They recently included our pediatric dentistry colleagues as well, because they actually do a lot of breastfeeding too. And so once again, their whole, so although everybody appreciates a lot of our other people who work in breastfeeding, other lactation consultants and nurses and members of AHEC, this one is, organization is exclusive to the medical provider with it. And the reason is they want to make sure that everything is evidence-based and that it has research as the basis. And so they actually, on the web, you can just look at bfmed.org, they have these protocols you can just go to. So if you're looking to find out about how do I deal with mastitis in an evidence-based way, you can go on here. How about engorgement? And they continually add more of these protocols and they're reviewed as well. And then like I said at the very back, if you want to pull some more papers, they'll always have a very scientific bibliography. So I would definitely recommend this as a resource. And then if you are looking, if you have a mother who is lactating, so whatever specialty, you're going into ortho, but you have a mom who's lactating and you need to know if the medicine you're giving her is compatible, there are two different resources that I personally use. First is free. You Google, it's from by the National Institute of Health, and they have something called LactMed. Okay, so you just Google LactMed, you can put in your drug, and it'll tell you if it's compatible with breastfeeding or if there are concerns. You know, so you can check risk and benefit for a baby. I also use Thomas Hale is a pharmacist who publishes medications in mother's milk. He also has an online site, but unfortunately there is a fee for this. Now, hospitals that you are associated with may cover this. Mine does, and so I will usually use his as well because it also will tell me the latest research and, you know, probably okay, but there's no research, and so it gives me a lot of good information that if I'm counseling a mom on whether that drug is okay. I also like Hale because he has a section on radiographic contrast agents because I get a lot of calls of, you know, mom needs to go for this procedure. Is it okay? Does she need to pump and dump? If she does, how long? Because let me tell you, the automatic kickback is usually mom needs to pump and dump for 24 to 48 hours, and usually it's not that. Okay, so these are some good resources if you're looking at interactions of medicines, contrast, things like that, and breastfeeding. Okay, so as I am going to wrap things up, here's the bottom line. There is a reason. It's not just intuitive. We're mammals, we're warm-blooded. Our milk is species specific for nutritional and non-nutritional benefits. The American Academy of Pediatrics has issued very strong statements, once again saying that evidence-based studies have confirmed and quantitated not just the benefits, but the risks of not breastfeeding. And it really is not just a lifestyle choice, it really is a health issue. Things are changing. Across the state of Missouri, across the nation. You know, we see Selma Hayek nursing a starving Ethiopian baby. And my goodness, when breastfeeding is there on Sesame Street, we know things are changing, right? Mm-hmm. So breasts not just for selling cars anymore, but actually giving public health. So, as a provider, your advice to the mom is critical, okay? It's your gift to the mom, it's her gift to her baby. And even though it may not seem like it anymore, what we say as provider matters. So if you don't say it, you're not promoting health. So caring, ethical professionals, we are our patients, accurate information, appropriate guidance, and long-term support. And let us continue to promote what is best for infants and moms and actually long-term health for all of our patients. All right. So I have a little type of questions if anybody has any.
Yeah, I heard several providers counseling their moms on not letting baby latch on for more than 100 minutes if it's really big districts or breast pacifier them.
So you're right, I hear that too. And I may have even said that earlier with it. We don't really limit nursing times. What's really important is the way the baby is latched. Okay? So it is true that if we have an improper latch, we can certainly cause damage to mom's nipples, and that can decrease her milk supply. And you know, if you feel like your nipples are going to fall off, nobody's really going to want to breastfeed. So I would say it's probably more important for not the timing, but really that the latch is appropriate. And if mom's comfortable and it's not hurting her, there's no reason not to. You know, Skin to skin does a lot of things for babies. And so being down at nipple, being able to regulate temperatures or regulate heart rates, regulates glucose metabolism, increases oxytocin levels. And so no, we don't counsel that. We don't limit. Other questions?
Is there any data that shows, like, in the past, like, rates of breastfed versus bottle fed and, like, the rise of, the obesity epidemic?
Absolutely.
Yeah. It seems like that's
there's actually quite a bit of literature that looks at that as well. And once again, it's because the nipple can create more of a passive flow. But when we talk about getting milk from a breast, we really are talking about a milk ejection reflex. So we have to have a certain suction, and it doesn't just free flow out. When you get the milk ejection reflex, you can see the spurting of the milk. But once again, it's not going to be as a big flow as what you see with passive milk.
Yes. Missouri, in particular, it seems like has a very high poverty rate. And why then do a lot of moms choose to use, or a higher proportion of moms use formula in Missouri when it's so expensive versus breastfeeding, which would be free?
So actually, I just kind of I had a presentation on this just last week in Joplin. We've seen a lot of change in breastfeeding actually over the last 100 years. In the 1900s, most women breastfed, and they actually breastfed all the way through 9 months and didn't introduce complementary foods till then. In the 1920s, we started learning more about vitamins, and then we started recommending supplements. Oh, we need to add vitamin A, we need to add vitamin D, we were giving cod liver oil, we were giving orange juice. And then in the 40s, we started seeing physicians starting to recommend introduction of foods earlier, around 4 to 6 months. The 50s hit. This is our postpartum war era. So in World War II, our men were mobilized, our women went to work. It's very difficult to continue nursing and trying to work, and they had to support the families. And so then we saw some pediatricians actually recommending starting complementary foods at 4 to 6 weeks. So they were not being exclusive. We're doing other food sources. Also, that's when we started getting better sanitation and hygienic practices. And that's where we got better with our artificial breast milk. Before then, people tried cow's milk, they tried goat's milk, they tried doing condensed milk and adding a few things. But then that's when our formula companies actually started coming online. And they made a product that really was a lot safer, and it was beneficial in those cases where mom could not provide breast milk. Then, as we started introducing complementary foods, we had some other baby food companies come online along with the formula, and it became a little status symbol. Here is this nutrition in the mom, and I can afford it, and it's a big status symbol. Then we also had some physicians saying, you know what, your baby only needs breast milk for this long, and we're introducing. So then as physicians, we started saying, formula is so scientific. You know what, it's clean, there's no bacteria in there. This is the best thing for your baby. So as a medical community, we started doing that. Just come on, just quit smoking, right? We would say, this is healthy, have a let's try type of thing. And so that became into our community. And so we started having moms who never breastfed. And then those moms would have daughters, and they didn't help them breastfeed, right? They weren't particularly supportive, because then we started seeing guilt issues, like, oh no, it really is better for my baby. I didn't do it. I don't want to, I'm not going to, it's hard for me to promote it because we have this type of thing. So we have all of this in our culture. And it really took, I think, science to say, well, does it really matter? Maybe it doesn't. And until we have the research, I don't think really any of us could say that, from an evidence-based perspective. So now it's coming out. Now we're seeing the pendulum start swinging again. Really, the 70s we started swinging, 80s, 90s, and then, like I said, since we're seeing all these organizations coming out, and then our government starting to put teeth in it, that I think we're going to see going back to truly what was physiologic and that had a purpose. So it's more of, I think, a historical kind of a comment on our culture.
So today is the most common excuse for women who choose not to breastfeed. Is it just the lack of information they have, or a misconception that formula is just as good as breast milk?
So I think it's a lot of things, and I think it depends on which society you're in. I did my pediatric residency in New Orleans, and I actually did a prenatal point talking about this. And a lot of the women that I had were the group that I served in Cherry Hospital. We had a higher proportion of a lower socioeconomic, and we had a lot of who still remain kind of our lowest numbers when you look at different races across on breastfeeding. And I would actually have moms tell me, "Oh, honey, I'm not going to do that. My partner is ready for me to, be back in action or whatever, and I don't want a baby on the breast." Look, disgusting. And so, we had a very different perception that we had to try to overcome. So I see cultural stigma with that. I see, once again, oh, I can afford formula. I see that's a lot, or I don't want to be tied down. I'm ready to get back in here. And I see a lack of education. I came out of residency saying, breast is best. That one was probably okay too. And and I thought of myself as highly educated. So I think it's a combination of factors that really do. And so, and I think that, if we don't, talk about it, then we don't really think about it. Okay. And that's one of my purposes for taking a kind of point to come and chat with you guys too, is that I hope that you're not going to be like I was going, yeah, I'll serve on that committee, but I'm not really sure I'm your best choice. That's I'm going to take any questions from outside if there are any. All right. Well, it was a pleasure. Thank you very much, and I appreciate your attention. And if there's anything else that you guys need to ask